Okay, we're going to begin the next session, everyone. It is my privilege to introduce the first speaker in this session, Lavinia Alberi. She is a academic turned entrepreneur. Yes,
Entrepreneur.
Academic turned entrepreneur. Okay, she's the founder and CEO of Vitalize DX, and she'll be talking about classifying dementia progression.
Yep. So I think we are at a stage where we really are looking for not only therapy, but what we have to start with is early diagnostic. We know we have a therapeutic window, and this is not really when the symptoms, the cognitive symptoms starts. So we really need to do patient stratification early on at the time when those pathological processes are starting accumulating, amyloid, tau, and we really need to differentiate those patients. So when I was turning from being an academic after about 15 years at the university, also having trained here in the US and then returned because of my mother, she had FTD with ALS, and I had to return to Europe, closest to my hometown, which was Switzerland. I really started to get passionate about understanding what were the drivers. And drivers are cascading drivers. And we know that microbes come in many fashion, but there is one ideal port of entry, which is the olfactory route or the optical route, which are devoid of the blood-brain barrier. We know now that there are ways to surpass the blood-brain barrier, and there's also aging that comes into play where there is permeability of the blood-brain barrier. And we know also that there is genetic variability and genetic susceptibility where there are certain genetic factors that can weaken the innate immunity system and really make it more permissive for invasion. And so this interplay between virus and bacteria really came to me as a really quite a large arena where I could start looking into novel application and really trying to underpin this interaction between the microbiome and the host. And what is the best biofluid to look at it? Completely non-invasive, very suitable for first line of screening and really rich in biomarker. It's not a surrogate of blood. It's a filtered biofluid, very, very rich in soluble biomarker, but also in biomarker, which is transported in vesicles. And so I will show you how effectively we can start looking at microbes that can really classify dementia progression, proteins of the innate immune response that also kind of determine this progression. And then I will show you some of the data from the transcript that are contained in those salivary vesicles that are intact and really recapitulate immunological responses, vascular responses, and also some neurodegenerative responses. And actually, this was really the progression also of my career because coming from academia and then going to my own company, well, funding gets tighter and tighter, and being in Europe, it's even worse. So you will see that I kind of adopted strategy along the way in order to continue researching, but of course with some methods that are just incremental, and they're really optimizing all the resources we have available. So the oral microbiome, of course, when I started, it was 2016, I started the study looking at salivary diagnostic as an early detection method to really triage the population. And at the time in 2019, this paper, wonderful from Dominique, came out, and they showed that there was a good correspondence of the increase in accumulation of gingipains in the brain. And interestingly, while they were seeing that in CSF there was an accumulation of gingipains, well, in saliva actually this signature was decreasing. So I was thinking, oh, this is interesting, but also a little bit contradictory. Is there an evasion? Then there was another paper that actually kind of said, no, this is not, it's the typical debate that happens in our field. However, I was already, in the midst of this study, and what we did not only look at saliva, we started with sensory and chemosensory triaging. So we used cognitive testing, and on top of this, we did also olfactory testing. Olfactory testing is extremely easy. Doty gave us the UPSIT, and we can do the UPSIT. It takes about 15 minutes with a demented patient. Maybe it takes a little bit longer, 25 minutes, but you really can match those two tests very easily, MoCA and UPSIT, and you get a very good segmentation. And of course, this two populations were segmented according to the cognitive in group A and group B, or group demented and control. They were further characterized in high cognitive ability and high olfactory ability, or high cognitive ability and low olfactory ability. And we see that effectively, instead of having two groups, of which we have a progression in AD, we have four groups. We do have a cognitive healthy population, which is actually has olfactory deficit. And this is what we call the cognitive normal at risk. And we have the MCI, which have basically the same risk or the same score for olfactory deficit than the cognitive normal at risk. And so we obtained those four groups, and really we start looking at those four groups. And we look at through S16 sequencing at the microbial population. We couldn't really see much of a diversity change, but when we were doing the classification, we actually were able to see that those microbial signatures were very different across those four groups. And so we looked at basically the philia and the phylogenetic signatures, and you can see this is just a comparison, the pair comparison of the cognitive healthy versus the cognitive normal at risk, which had impaired olfaction. Then we had the cognitive normal versus MCI, and the cognitive healthy versus the mild and moderate AD. And you can see that really what's happening, it's that you have a lot going on in MCI, which is starting in the stage of the cognitive normal at risk, and a little bit less happening in the mild and moderate AD. And if we look at the non-discrimination analysis and we really look at the families, you can see that in MCI, there is a lot of change. A lot of changes is going in the direction of actually a decrease in the number of species and is maintained in the AD. I'm rerunning this data over and over because we have also a longitudinal cohort, and actually this is recapitulated using a recent algorithm from one of my students. So what we saw is actually is that we have a decrease in those species, phylofactor species, and periodontal pathogen species, a little bit what they were seeing Domini and the colleagues, whereas we found actually that opportunistic species as Leptorica vidae and Cardiobacterium valvarum were increased progressively in those stages. When we did and tried to assess the sensitivity of this classification, just looking at the single species, we don't have a good discrimination capacity. If we put them all together, it becomes better. But actually, if we do put them with the UPSIT, this becomes even stronger. We have really, if we cluster all the species, we have a very high discriminative capacity for the CNH and versus CNR, and MCI versus CNH, and also mild and moderate versus CNH. Now, I'm starting to go to more simple experiments and more simple tests, and I'm using some strips just to go back to saliva. Saliva can be frozen, you can take it out, the metabolites are still there, and now we're starting to look at metabolites, nitrate, uric acid, prebiotic nitrate. At this particular stage, we're not seeing much of a difference. But if we run the algorithm, we see that actually there are drivers of those metabolites are different. For example, if we look at uric acid is driven in the control group is driven by H. So the increase in uric acid is driven by H. On the other hand, is driven by nitrates. So even if you do see the same things, we have methods nowadays to see which are the drivers. And I think that we have a lot of power nowadays to go deeper. And if we do some difference, or we don't see some difference, it's important to understand what are the drivers. So just to conclude here, we did find that there were signature specific for the oral microbiota that were basically distinguishing the progression of AD. We were able also to identify this group at risk. Now we are characterizing this group at risk after 3 years. And we were able to see that periodontal keystone bacteria were actually being reduced, where we had opportunistic bacteria which were increased. And afterwards, I will show you now how the host responses are also changing. And this was another paper that we published later, looking at proteomics of saliva. Again, very easy. It's just we use shotgun proteomics. We had very, very little resources. Basically, we had almost no funding for this, but we were able to publish it. And what we did, we weren't able to do all the four groups, but we did do the CNH, the MCI, and the AD. And this project really started earlier on when I became the lead of neurology into an innovation center. And I wanted to see whether saliva was a surrogate for CSF. And I was very excited because 1/4 of the proteome of saliva was effectively shared with the CSF. And then if we did a string analysis, looked at the functional interaction between those proteins that were shared with the LG set, we found strong functional interaction. And if you look at the gene ontology, you can see that the majority of them are effectively a part of the immune response, but there are also some genes and some proteins that are related to neurodegeneration. So we did the expression profiles for after the proteomics, and you see that in saliva, actually, you have general reduction of protein as compared to CSF, where we had an increase in protein, and those proteins were well distributed. We found one specific protein which was of great interest, the transthyretin. Transthyretin is a protein that is involved in amyloid degradation, and there is actually a pathology, transthyretin amyloidosis, that is typical of misfolded TTR, and TTR doesn't function. And what we see is that basically in the progression of Alzheimer, you have a reduction of TTR as you would have an increase in amyloid. Now, amyloid has been found in saliva, also increased, and we don't know which species, probably Wenshi, or we will hear more from Lighthouse Therapeutics, whether we have it in the biofilm, and specifically in the clavicular fluid. But what we found was that effectively TTR was significantly reduced. And we did have actually another protein that, however, because we didn't have enough resources, was S100A9 and S100A8, which were strongly upregulated. So what to do when you don't have resources? Well, then COVID hit, and I basically did only COVID tests. I developed a method. We were basically doing 1,000 tests a day. And this method basically allows you to see both viral or exogenous nucleotide and also endogenous nucleotide, depending on the time frame where you're cooking your samples. And basically, you can do really quick qPCR. And so based on this, I said, okay, I will start looking at immunological changes, immunogenic changes, just by using the method I patented, I'm selling. And so basically, I just selected those genes that were highly connected and they were present in vesicles and that had a functional link. So I did kind of a very targeted fingerprinting here and looked just at the genes that were connected, which were coming also out of the previous screen, and just concentrated on this. And funny enough, we do have some very significant changes. And you can see that both the S100A9, which we were seeing before in the proteomics, but we couldn't confirm in protein, was induced in the even the CNR and the MCI and AD and HLA-C. B2M, it's a vasculogenesis gene, which was also increased. And actually, we do have some genes which are involved in the amyloidogenic, which are decreased. So before, when still the resources were good enough, we actually were able also to profile in cytokine from the innate immune response. At that time, when we did the classification, we were not really able to see any difference among those strata. But when we were looking at the single cytokines, we saw that in the cognitive normal at-risk population and the MCI, effectively things were going on and nothing was happening in the mild and moderate AD. And so we did identify effectively interleukinase and interleukin-1 alpha and MIP-1 alpha, which were increased in those segment. And we can say for sure that if we all look, too late, we're not going to see anything. So we really need to look earlier on. So what does it say in the end? We do have immune responses. Immune responses are probably going together with the microbiome changes. Now, we need to think of causality. Of course, we do have evidence that also from the Domini paper and other work is just being done that Porphyromonas gingivalis and other microbiomes can get to the brain and can cause a microbial response. But this microbial response, we might be able to see it even in peripheral biofluid, in easy to access peripheral biofluid like saliva. And we have characterized at least TTR, which goes down and might cause this amyloidogenic response. S100A9 is one other biomarker. The vasculogenesis genes, BM2 goes up, and we have also amyloidogenic gene C3, which is also immune repressive gene. So just very simply, I'm not stating that saliva is going to be the next diagnostic. I'm stating that we need more research, and certainly I would like for the future in the next 5 to 10 years to see the first line of testing happening at the GP and as a really triaging and kind of checkup instead of doing. In Switzerland, everyone loves to do gastrointestinal checkups, and no one uses blood tests. But I know that in the US, the healthcare system is sensitive to costs. So I think that salivary diagnosis certainly has a big opportunity, and that we need more of those profiles and those panels that really read out our overall health. So the overall conclusion is that beside cognitive, we need other tests, other very simple tests. Chemosensory tests are very simple. We were looking at identification, but you also can look at olfactory memory and also differentiation. And saliva microbiome really reveals those changes that are stage specific. Transthyretin reflects amyloid metabolism, but we can also see that there are also inflammatory changes or immune changes happening. Those can be detected by protein, by also, we have seen that there are sensitive methods also to detect proteins, but we can also look at very specific transport in vesicles, and those can be detected by qPCR in a very cheap way, in a very accessible way. So I would like to thank everyone for that was involved in this work. The transition from academia to being an entrepreneur has been a pleasure, but also a great endeavor, and certainly the LSPI Pathobiome Initiative is not only an experience for me as a sidekick, as an entrepreneur, but it's a great family. And as I said, for me, it really takes the courage and a little bit, going beyond boundaries. The sky is not the limit. And my future is really a future where you have salivary diagnostic as first line of detection of some biomarkers. I'm just putting here a salivary strip, which I'm developing for sports, for athletes, where you basically would be able to then either go for further testing or really get some simple, maybe antibiotics or anti-inflammatory, or you name it.
Wonderful. Thank you so much, Lavinia.
Thank you.
Okay, our next speaker is Michael Detke. He is the Chief Medical Officer and co-founder of Lighthouse Pharma and a professor of psychiatry at Indiana University School of Medicine. Welcome.
Thank you. Here we go. Thanks, Nikki. Let me start by thanking the organizers for, we're honored to be invited to present and are very pleased to be co-sponsors at Lighthouse Pharma. For those of you who don't know, Lighthouse Pharma is kind of the successor to Cortexime. So I'll be showing you a blend of data from both of those entities, but most of the leadership, Steve Dominy, Casey Lynch, myself, are the same across both. And we'll be talking about treatment of P. gingivalis positive Alzheimer's. These are my disclosures. And I'd like to thank virtually all of the prior presenters today for making this section of my talk so easy and having queued up so many important data that are relevant to this. This slide is supposed to just give a high-level overview of not only all of the data that support a pathogen being involved in Alzheimer's and in some cases specifically P. gingivalis. But this is actually what convinced me to come to Cortexime back in 2018 when Casey Lynch called me up. I had another job. I was happy with it. I told her I wasn't looking to move. And she said, yeah, Mike, just let me walk you through some of the data for 30 or 45 minutes. And as a scientist with all of these data coming from all these different domains and converging on the same conclusion made it, I was convinced I had to see this further. And as just one example, this study was already referenced by one of today's earlier presenters, and some of the others that I'll talk about are as well. I think this has been referenced already a little bit. This is the mouse model where you take human oral P. gingivalis infection and just simply rub it on the teeth and gums of wild type mice. And this induces really significant AD pathology. You see PG and/or gingipains in the hippocampus by qPCR and immunohistochemistry, but not in controls. Gingipains are localized intranuclearly and paranuclearly in not only neurons, but also microglia and astrocytes. Significant evidence of immune response with IL-6, TNF-alpha, et cetera. Neurodegeneration and cell loss in the hippocampus was evident in the experimental group. APP and BACE1 gene expressions increased. Really just all of the pathophysiology of Alzheimer's recreated in this model nicely. And you can read the rest there. And then was the discovery of gingipains in human Alzheimer's disease brains. As I emphasized on that earlier slide, a lot of our work has been done in collaboration, or that paper with the 6x risk factor for Alzheimer's among a spouse of an Alzheimer's patient. They were published entirely by third parties. This was done in collaboration with Neurovalida and University of Auckland and their brain bank, but also others too. You can see Hatise Hasterk's name on here. She has been our primary collaborator, but among many at the Forsyth Institute, you learned a lot about the Forsyth Institute today earlier from Dr. Shi. And we saw here that gingipains, these cysteine protease virulence factors that are these proteases that are released by P. gingivalis, were identified at high rates in AD brains, and that those levels correlate with AD diagnosis, with tau and ubiquitin pathology. And the gingipains are directly neurotoxic and fragment tau, and oral infection of wild-type mice with PG results in PG brain invasion, induction of A-beta 1 to 42 alpha that can be blocked. And then what we were able to show then that the 5 or 6 other labs that have replicated these major findings is that we had small molecule gingipain inhibitors that we had developed in-house, and we were able to show that these reversed this. Again, this is data from showing the gingipain load in human brain correlates with AD diagnosis and pathology. There are 2 kinds of gingipains, as many of you probably know, arginine and lysine gingipains. Both independently showed significant correlations with AD, tau, ubiquitin at highly significantly higher levels in the brains of former AD patients than they were in age-matched controls. However, you still see some in age-matched controls, which is entirely consistent with having this infection prior to onset of the clinical disease, again, consistent with Koch's postulates. And I already talked about the controls. And intraneuronal gingipains were confirmed in neurons of AD hippocampus with bright field and IHC, and they've shown to co-localize with tau tangles and so forth. Further, tau is cleaved by gingipains. I think Dr. Alberi, one of my again predecessors, showed some of these data as well. So thank you. Tau is cleaved by gingipains into fragments involved in tangle formation. In cells that express tau, infection with PG showed a dose-dependent cleavage within an hour. PG gingipain defective mutants showed intact tau levels similar to uninfected cells, indicating that this is caused by gingipains or involved gingipains, and cleavage sites were identified within recombinant tau using purified gingipains and mass spec. And an independent research group from the UK demonstrated that gingipain-generated tau fragments from paired helical filaments form paired helical filaments, which are, as probably most of you know, the basic units of tau tangles. So, and then back to the mouse model again briefly, and some of the effects on A-beta, and again, a lot of groundbreaking, really essential work was done in this area, again, by Dr. Amer, I think, presented, and some of his colleagues and mentors have done a lot in this space. But we showed that oral infection of wild-type mice with P. gingivalis results in brain invasion and induction of A-beta 1 to 42. And then again, we were able to block this with the gingipain inhibitors we developed. So in summary, and again, I don't think this audience needs as much convincing as many, but multiple international studies have shown P. gingivalis gingipains trigger or accelerate characteristic AD pathology in animal models. And then we developed molecules that specifically block the gingipain. They bind covalently and therefore irreversibly block the gingipains. So we took an initial first generation 388 molecule into a large phase 2/3 clinical trial we called the GAIN trial. This was in mild to moderate Alzheimer's with MMSEs of 12 to 24 at baseline. We didn't use any specific biomarkers at the time of this study, and in patients with this severity of illness, it's a lot easier to diagnose them accurately without biomarkers. But hold that thought, and I'll come back to it. We tried 2 different doses, and we were able to enroll 643 patients in between 2019 and 2021. We had the typical co-primary outcomes, but we specified a priori that ADAS-Cog11 was for proof of concept. And before I get to the primary data, I wanted to show you some of these data having to do specifically with the oral microbiome. First of all, we didn't have any entry criteria in this study around dental disease of any kind. They had to have Alzheimer's. They came into the study. Nevertheless, we found 90% of these patients, by the usual clinical measures, had moderate to severe periodontal disease. And on the right, you can see that we looked at serum anti-PG IgG. We also looked at it in the CSF, and we looked at PG in saliva, and I'll come back to that in a minute. But you can see virtually all the patients had some levels of serum anti-PG, and about 4 out of 5 had levels associated with periodontal disease. One more key thing on some of these biomarkers, the baseline CSF anti-PG IgG levels indicated PG CNS infection in virtually all of the patients. There was a subset of the 643 that underwent lumbar puncture, and that was 472. We made that optional, and then we made it mandatory because there weren't many people signing up for it. But the anti-PG IgG concentration in CSF was largely independent of the albumin index, as you can see here, indicating central nervous system production. Only a small percentage of gained subjects had loss of blood-brain barrier integrity as measured by a higher level of albumin index. And these antibodies suggest or support a direct PG infection in the CNS. And then this is getting to the primary, the key clinical outcomes. Across the entire 643 intent to treat population, we did not see efficacy. However, these were 3 pre-specified subgroups based on obviously reasonable biological approaches. These are 3 different measures of basically higher infection with PG. On the left, PG in saliva. We just heard a whole bunch about saliva tests. We will be going forward with a saliva test for PG, as you'll see. And for those of you not looking at clinical trial data all the time, this is the placebo group, and it declines as you expect without treatment. And you measure efficacy by showing how much reduction in decline there is. You can see, so this group, the low dose group had about a 42% slowing of decline, and the higher dose group had about a 57% slowing in that subgroup. And then we also looked at high anti-PG IgG in both serum and CSF. Virtually all the patients had some level of IgG, so we did median splits here. This is just the high half. And again, you can see sometimes statistically significant, sometimes not, but all of them trending in the same direction. As further sensitivity analysis of this, a lot of times the data especially in Alzheimer's, are non-normal. So that there'll be skewness and kurtosis in the distribution, in which case parametric statistics can be inaccurate. So we also did non-parametric analyses of this. And the major takeaway here is that all of these look largely the same. All of them look like at least the higher dose appears to be, well, really both doses appear to be efficacious here too. This by itself shouldn't convince you, but as a sensitivity analysis, it supports the findings of the last slide. And then, and those were specified a priori as well. On the right is one more, and this one was post hoc by a very creative statistician who just included in the statistical model some of the baseline scores on other clinical scales. So not just the baseline ADAS, but MMSE and others. And again, this shouldn't convince you by itself, but the fact that these are all in the same direction is supportive that this is not a false positive. You should really be asking yourself the question, this is a subgroup, is it a true positive or could it be a false positive? This slide shows that P. gingivalis infection was reduced by treatment, which also supports the outcome. And then this, to me, I think is one of the most convincing outcomes that supports the primary clinical finding, especially on the ADAS-Cog. These are correlations between change in PG in the first 6 months of the study, and then the clinical outcomes at 6 months and at 12 months. And as you can see, the nominal p-value of the first one is 0.0001. So that would suggest at least a 1 in 10,000 chance that it would be less than 1 in 10,000 that this would be a false positive. But it's also nice supportive evidence of these as biomarkers that are tracking Alzheimer's clinical data. We also looked at brain atrophy. We did not see much of a signal on the hippocampus, but I think that's consistent with the literature in general that hippocampal tissue loss is mostly earlier in disease, and these are in kind of later phase disease right now. We did see some slowing of whole brain atrophy and cortical atrophy. All of them looked like they were slowing. All of them looked like the slowing was a little bit clearer in the PG positive group, although these were not all statistically significant. And then I'm really obligated to bring up one key safety finding with this first generation gingipain inhibitor, which is that it seemed to cause some liver safety issues. There were 2 patients that hit what's called Hy's Law, which has elevated AST or ALT and bilirubin at the same time, which can be very dangerous. Fortunately, in that trial, we were doing population pharmacokinetics. So we had blood levels on the patients. We correlated the blood levels of both the primary, the drug, and the major metabolite of the drug, and correlated those against the peak levels of the liver function tests, AST and ALT. And at the bottom, you can see that the major metabolite correlated very, very well with these. It turns out the major metabolite was also being very highly sequestered in the liver. So that major metabolite is almost certainly the cause of the liver safety issue. So we've gone on to, so in summary, and hold that thought, we really felt like this was a very, very positive phase 2 study. It was a great proof of concept. It certainly wasn't a pivotal or type of study that the FDA would accept. But we found that drug exposure was correlated with bacterial load. We saw efficacy in multiple different pre-specified logical populations for the mechanism. And it made it clear that we need a companion diagnostic. So we're going into next steps with a second generation gingipain inhibitor, completely new structure, but the same mechanism of action. It binds covalently to the gingipains. It penetrates brain, cell, and biofilms. Composition of matter patent is issued, and it's highly selective. It's a once-a-day pill instead of multiple times per day. And I'll show you the phase 1 data. And very importantly, the third line from the bottom, it does not make that metabolite. It has a different major metabolite with a different structure. Very quickly in the phase 1 data, you can see the chart in the upper right. The PK is nice and well organized. The table on the lower right, almost nothing in terms of safety signals. It penetrates the brain. We did a subset with lumbar punctures. And the highest dose we plan to develop in the next trial is 50 milligrams. So we've already taken this to 4x the dose, and it's actually 7x the exposure in humans with a great safety profile so far. This is the spring trial, which we planned for the second generation, Lighthouse Pharmaceuticals LHP 588. It's essentially a copy and paste of the GAIN trial. Your eyes are not confusing you. With the exceptions, the upper left there that are underlined, we will use a PG positive saliva test. And at this point, with the evolution of the Alzheimer's diagnostic field to include biomarkers for that too, we're also planning to use plasma p-tau, 2 doses. We think we can power this better with a smaller population. And then this is our plan going forward to work on LHP 588 at the top there, start the spring trial as soon as we raise money. We're raising money to support the running of this trial. Everything else is in place. And so I'd like to also acknowledge many collaborators. I've already mentioned the Forsyth Institute and all of my colleagues at Cortexime and Lighthouse, some superb clinical advisors in the Alzheimer's space, but also Mark Ryder is a former chair of periodontology at UCSF. So we have some excellent colleagues in that area as well. So I will stop there and thank you for your attention.
Michael, that was great. Thank you so much, Michael and Lavinia. So it's absolutely my honor right now to introduce our last talk of the day. Certainly last but not least, and one of our keynote speakers, tremendously honored to have Colonel Nicole Malachowski here with us today. I'm actually going to read some of her achievements because I won't do them justice if I try to remember them and rattle them off. She is a 2019 U.S. National Women's Hall of Fame inductee and a presidential appointee. She has served over 21 years as an officer, leader, and fighter pilot in the United States Air Force. She has spent and accumulated over 2,300 flight hours, 188 of those in combat. She is the first woman Thunderbird pilot, serving also as a White House fellow and an advisor to the First Lady of the United States. Nicole, I also had the privilege of being in Dayton, Ohio at the Air Force Museum with my children this year, and I got to stand next to her flight suit with my kids. So she's just an unbelievable individual. She, like me, suffered late-stage tick-borne illness and also has been advocating for many years for better acknowledgement. So I thought no better way to finish off a day of bridging silos than by breaking barriers with Colonel Nicole Malachowski.
I'm the outlier. But I'll tell you, I know you all like to be outliers as well, and that's what makes this group so special.
That makes you an inlier.
I'm an inlier. Are we all just outlaws together? We can all just be outlaws together. No, but thank you, Nikki, for that introduction. I am gonna have to start with a little bit of a confession, and that confession is I've been sitting up there since 9 a.m. and 90% of what you all have said has gone completely over my head. All right. So I didn't understand a darn thing. All right. But here's what I do know. All right. What I do know is that we are in a room that's full of greatness. And I don't mean that to be trite. I'm not pandering at all. I have been amongst greatness before, and I know what it looks like, and I know what it feels like. And that kind of greatness is here in this room. It's the kind of greatness that it's going to take to break down silos, to break barriers, to help people. Because why are we here? It's not to do one more scientific test, I don't think. It's not to advance one little piece of things. We are here because we're a group of human beings who want to help other human beings and never lose sight of the ultimate reason why you do what you do. It's to help take away human suffering. It's to care for other human beings. And that's what I am picking up as an outlaw way over here in the corner, not understanding a darn bit of the science that y'all are talking about. But I have learned a thing or two also about what it means to break barriers. And so, you know, I'm sitting up there with imposter syndrome thinking, what in the world am I doing here? Right? And you might be thinking the same thing, and that's cool, that's okay. I'm not easily impressed or intimidated, I'll admit that. But I will tell you, like, what in the world does an old washed up fighter pilot and a harried mother of 14-year-old twins possibly have that she can impart in a bunch of extremely wonderful scientists and medical folks here working on Alzheimer's? And I'll tell you, after 21 years of service, I learned a thing or two about what it takes to break barriers. And to me, it's all about having the courage to be different and go against the status quo. It's all about having the trust to put your ego aside and to work cross-functionally. And it's all about having the vulnerability necessary to admit when things go wrong, when failures happen, and to deal with the unexpected. So it's all about courage, trust, and vulnerability, which is what I'm going to talk about today. But before we do, I wanted to introduce you to my laboratory. This is my office. This is where I worked for 21 years. Yes, thank you, thank you. Yeah, thanks. The mighty F-15E Strike Eagle. I think it's the greatest fighter aircraft ever invented. I like to thank you, taxpayers of America, for letting me fly that. But that's the plane that carried me and my friends safely in and out of combat more times than I could count. She is a beast, and yes, it's a she. Don't forget that, okay? Now, I am not a scientist by trade. Actually, I have a bachelor's in management, a minor in French, and 2 masters of arts in national security strategy. But even I have loved this quote for a very, very long time, because I think this is the kind of mindset we need in order to overcome status quo and pummel dogma when it needs to be pummeled, all right? So this is kind of what I was thinking about getting here with all of you guys. This is the quote that kept coming to my mind, and I hope it inspires all of you as well. But before we get into some flying stories, I thought we'd watch a flying video, because flying videos are cool. And there is an expectation that the fighter pilot shows up with a flying video, but I'll admit there's also a point to this video as well. If you take a look on the screen there, that's actually me you see in the cockpit. You'll notice that's a different aircraft. That's called an F-16 Fighting Falcon. I also flew that as well. It's painted in the red, white, and blue colors of the United States Air Force Thunderbirds. All right, now how many of you in this room or even watching have seen the United States Air Force Thunderbirds fly? All right, cool. All right, how many have seen the equally amazing US Navy Blue Angels? Yeah, yeah. They also had a really cool movie that just came out. So if you haven't watched it, go watch that. And I know we've got an international audience as well. You know, we've got the Canadian Snowbirds, the British Red Arrows. Most people are familiar when the air show comes to town. I mean, when the air show comes to town, that's a big deal. It's all over the media. It's advertised. It's exciting. It's a patriotic event. It's a family event. There's technology. There's speed. There's loud noises. There's, you know, funnel cake and warm Budweiser. Like, right? Like, people are happy to go to air shows. Now, I had the privilege of flying as Thunderbird number 3 in the right wing position way back in 2006, 2007, the first woman in history who had the opportunity to do so. And I get asked this question all the time, Nicole, what was the best part about being an Air Force Thunderbird pilot? Because it really is like being a rock star. You do get treated a little bit like a celebrity. And they're like, what was your favorite part? And people think I'm going to say the flying, which was fun and cool. People think I'm going to say all of the travel, which included international travel. Yeah, that was cool. People think meeting all the famous people and celebrities, that's interesting, but not compelling to me because honestly, I'd rather be in a room full of people like you. I can't tell you how excited I am to be here rubbing elbows like with my Shiro, Monica Embers, right? And my hero, Dr. Ed Breitschwart. Like, you're much more important to me than any of the famous people that I met. So none of that gets to the heart of the answer. Nicole, what's the best part about being a Thunderbird pilot? Well, the best part happened after we would land. So we would do loops to music for 30 minutes, and then we would land and we would walk over to the audience or the autograph line, where we would answer questions, take pictures, sign autographs. And the strangest thing would happen, and I still don't understand it. People would come up to me, and it was adults. It was never kids, always adults. And they would look at me really interesting. They'd be like, wow, you're a fighter pilot. That's cool. And then they'd look at me and they'd be like, wow, you're a Thunderbird pilot. Well, that's kind of elite. And then they'd look at me like I had grown a third eye, like, you're a woman Thunderbird pilot. Like, I'm not sure what to do with that. And then with a straight face, people would look at me and say things like this. You must somehow be different than us, Nicole. You must somehow, Nicole, be naturally gifted. The path in front of you, Nicole, must have just been smooth. And I would smile and demur because I think they were trying to pay me a compliment. But inside, I'm thinking, you've got to be kidding me, right? I mean, the path for me to get to the cockpit of that red, white, and blue F-16 was littered with twists, turns, bumps, bruises, mistakes, failures, all along the way. As I'm sitting here learning about all of you, listening today, thinking back on my story, I'm just reminded of a lesson I learned a long time ago, which is this. The path to success for any individual or for any team will always be nonlinear. The path to success will always be nonlinear. Now, this video was taken my first year on the team way back in 2006. It's about 1.5 minutes long. 50% of the in-cockpit video comes from inside my jet. So it's your chance to fly as Thunderbird number 3. I hope you enjoy it. do miss that flying. I do. Thank you. Thank you. I show that too because I think it's a great visual representation of what I mean by courage and trust and vulnerability. It's also a lot of fun to watch all of your faces when those 4 jets cross at the end, right? I know you want to know. So with context, when we cross at the end there, we cross with about 1,000 miles per hour of closure at about 32 feet apart. The rest of the time when you see us flying in the close formation, we're flying at 3 feet apart, just to give you context. So let's talk a little bit about courage, the courage to be different, the courage to go against the status quo, the courage to pursue big, gnarly goals. Have you ever had a dream or a goal? And I know you do because I've been listening all day. That's so big, so gnarly, that the idea of like actually tackling it, pursuing it, or speaking that dream out loud, like you get a knot in your stomach, the voice in your head says that dream's too big, that goal is too hard, it's too gnarly. Maybe you have an idea that would completely, as I've learned today, revolutionize, right, how we do research in Alzheimer's, but you're thinking, whoa, that's a little too far out there. I don't want to be the gal that rocks the boat. I don't want to be the guy that goes completely against the status quo. So I'm going to keep that idea inside. I think we've all had moments like this. All right, I had a dream as a kid growing up to one day grow up and be an Air Force Thunderbird pilot. It's a pretty big, gnarly dream. A little bit of context about me. I grew up in Las Vegas, Nevada. Yeah, people are from Las Vegas, Nevada. Yeah, I always tell people, I'm way too short to be a showgirl, so I went with Plan B and became a fighter pilot. All right. But what's super cool about being a kid in Las Vegas, Nevada is there's an Air Force base there called Nellis Air Force Base. Its nickname is home of the fighter pilot. I grew up watching fighter jets fly overhead every day thinking, I want to do that someday. It's also home to the United States Air Force Thunderbirds. I remember being in high school, taking my brown bag lunch out of the football field, eating my peanut butter and jelly sandwich, and screaming overhead would come this 6-jet formation of red, white, and blue jets, smoke trailing behind them, and I would shake with excitement like kids do. And I would look up there and think, there's people up there. Like, I want to be one of those people. But I knew that it was hard. It's hard enough to become a fighter pilot. It's even harder to become a Thunderbird pilot. For more context, in the active duty United States Air Force today, there's 12,000 pilots. Of those, 2,000 are fighter pilots. And of those, only 6 on any given year have a chance to become a Thunderbird. It's statistically improbable that anybody becomes a Thunderbird pilot, right? But it's not impossible. But even though I had harbored this dream since I was a kid, every time I would think of actively pursuing it, the voice in my head would always say, clear as day, other people become Thunderbird pilots, Nicole, not you. And I kept that dream inside. And every year the Air Force sends out an email at the same time that says the exact same thing. It's ding into the inbox. We're looking for 3 new Thunderbird pilots. It's a 2-year assignment. 3 pilots are new, 3 are experienced on their 2nd year. Ding into the inbox, we're looking for 3 new Thunderbird pilots. Here's the qualifications, here's the application. Even though I was fully qualified and it had been my dream since I was a kid. Every year when that email came in, I would do the exact same thing. Ding into the inbox, delete, 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 delete. Other people become Thunderbird pilots, Nicole, not you. And year after year after year, I did that. Until 2005, I found myself getting ready to deploy again for Operation Iraqi Freedom with every single certification and qualification you could have as a frontline fighter pilot. Right? I was a flight lead, I was an instructor pilot, I was an evaluator pilot. I had everything you could have. Ding into the inbox comes that dang email. And as I read it that year in 2005, for some reason, like a light bulb went off in my mind and in my heart. And as I read that, I thought, why not me? Why not me? Why not you? Why not these ideas we heard today? And I remember I read that email and that light bulb came on and I slept that night very fitfully. I tossed and I turned and I tossed and I turned. And the next day, with all the courage I could muster, with a knot in my stomach and the voice in my head saying, don't you do it. I walked in and I spoke that dream out loud for the first time. I told my peers, my colleagues, my supervisors, my chain of command, I'm applying to be a Thunderbird. It was hard. But you know what was really cool? Generally speaking, people were tickled. Initially, people were really supportive. But then as the days went by, if I had $1 for every time I heard this, you know, Nicole, it's hard to be a Thunderbird. You know, Nicole, you probably won't get picked. You know, Nicole, if you've never had a woman before, are you sure you want to do that? And over and over and over, that voice of self-doubt started to grow. But I said, nope, stay focused. Put together that application, a big, gnarly, complex application, probably like writing a grant. I don't know. Right? Like, it is tough. I mean, you had to have a picture of you in uniform, a letter of why you wanted to be a Thunderbird, all of my annual personnel or HR reports, all of my career-long check ride or flying test scores, everything. But the thing that was weighted the most, the thing that counted the most in this application was a letter of recommendation from the first full bird colonel in my chain of command. Now, I am a young 29-year-old captain in this picture. At that time, a full bird colonel, that was a big deal. A full bird colonel, that was intimidating. I always tell people I'm now a retired full bird colonel. We're not a big deal. We're a dime a dozen, okay? But at the time, it was intimidating. So I get this brilliant idea. I'll draft the letter for him. All I have to do is go in and get his John Hancock. So I put this whole application together. I get a knot in my stomach, the voice in my head as I'm taking this application in, thinking, don't do it, Nicole. I grab that application, and as nervous as I could be, I remember this day like it was yesterday. I walk over to his staff. I slide that application across the desk. The guy looks at me. He says, you know, Nicole, it's hard to be a Thunderbird. You know, Nicole, you probably won't get picked. You know, Nicole, they've never had a woman Thunderbird pilot before. And the colonel only has one recommendation he's allowed to give. So we're not sure we want to waste it. Boom. Oh, sucker punched, right? Wind out of my sails. And here's what happened in that moment. True story. I reached across, grabbed that application, and I removed it. And I looked at him and I said, you're right. I am so sorry for having bothered you. And I walked out feeling embarrassed and ashamed. Other people become Thunderbird pilots, Nicole, not you. And I did what any self-respecting fighter pilot would do at the moment. I went across the street to the officers club and I grabbed a beer. Okay? So I'm over there drinking my beer thinking, thank goodness I didn't put myself out there. Thank goodness I didn't risk failure. Who were you, Nicole, to think that you could become a Thunderbird pilot? And I'm sitting over there drinking my beer, talking with my hands like fighter pilots do, talking to the guys about the days flying. And all of a sudden, this door right here opens, and in walks the wing commander. Now, the wing commander is a brigadier general. This guy is 6'5", the man's man, the poster child of the macho male fighter pilot, right? He walks in and comes straight over to me, makes a beeline to me. To this day, I have no idea why he's talking to me. I don't even recall what we were talking about. I'm just really nervous, looking up at him, drinking my beer, trying to hold my own. Right? He's looking way down at me. I don't know what's going on. Next thing you know, my immediate supervisor walks over. All of you in here running your labs. My immediate supervisor walks over and he goes, General, Nicole's applying to be a Thunderbird. Oh, ixnay on the Underbird page. I mean, neither of them had known what had just transcribed across the street. Neither of them knew that I had decided to remove my application. This is a mortifying moment. And in that moment, the general looks down at me, way down at me, and he says, that's great, Nicole. How's your application going? This is terrifying. I take a swig of my beer. I look way up at him, and this is what happened. I looked at him and said, you know, sir, it's hard to be a Thunderbird. You know, sir, I probably won't get picked. You know, sir, they haven't had a woman before, so I don't want to waste anybody's time. Everything everyone else had said had taken up room in my own head and was literally vomiting out of my own mouth, right? It's almost embarrassing to admit that. I almost never became a Thunderbird pilot at all. Except in that moment, General Mark Matthews gave me one of the single greatest pieces of advice, and it's a piece of advice I've used every time I get that feeling of self-doubt or that feeling that I'm a little too out there or a little too different. And I want you all to remember that as you try to knock the dogma out of this and you knock the status quo out of this gnarly problem you're going after. I want you to remember this. He looked down at me and he said, Nicole, nobody wants to lead a scripted life. Nobody wants to lead a scripted life. And he walked away and left me in the most awkward silence. But with those words, he lifted the weight of the world off my shoulders. He told me it's okay to dream big. It's okay to be different. It's okay to go against the status quo. He told me it's okay to risk failure in pursuit of personal and professional growth. And it's not so much that he's telling you and me to write ourselves into the script. Hear what he said. What he said there was, don't ever write yourself out of the script. And as peers and colleagues in here, don't ever write anybody else or their wild ideas out of the script either. Nobody wants to lead a scripted life. And it's a reminder of the power of our words to make or break someone else's dreams in your lab, in this cohort here, the power of your words to make or break somebody else's idea. And it's a reminder of talent management too. Where are you looking for talent and ideas? I guarantee you nobody Nobody saw me coming. Not somebody that looked like me, right? And I get asked a lot, did you ever get the letter of recommendation from the colonel? No, I did not. But I did get a letter of recommendation from the general. So, so imagine, hometown girl done good. I show up in Las Vegas, Nevada, right? I'm one of only 6 Thunderbirds. I'm supposedly an elite fighter pilot. I've got all the certifications and qualifications you had. I thought I knew everything about trust. I thought I knew everything about trust and teamwork. I had led my peers in and out of combat for 8 years before I ever showed up at the Thunderbirds. And I walked in that day, I remember it like it was yesterday, this beautiful red, white, and blue hangar. I waltz in like a fighter pilot does. And I said, hey, I'm Nicole Malachowski. I'm your new pilot. I'm ready to go fly. And I was met with nothing but silent stares. And I thought, well, that's kind of weird. So I kind of stood back and shrug it off. And I said, I'm Nicole Malachowski, your new pilot. You know, people go to air shows to watch us fly. I'm ready to go fly. And I'll never forget it. The senior enlisted guy looked right at me with a group of enlisted behind me. And he looked at me straight in the eye and he said, you don't get to touch our jet until I say you can. I took a step back. I'm thinking, this isn't a very good first day on the job, right? I looked at him inquisitively and he said, you don't get to touch our jet until you get to know each and every one of us. Our names, our spouses' names, our kids' names, our hometowns, our hobbies. Further, you, Miss Fancy Pants Pilot, you have to go do a little mini internship with every single career function on this team so you have a better understanding of where you fit into this highly interdependent puzzle. So you have a better understanding how if we don't do our job to a level of excellence, it impacts you. And if how you don't do your job to a level of excellence, it impacts us. You see, there are 125 people from 25 different career fields who came together to make that mission happen. And all it took was one of us, just one, not doing our job to the highest standards of excellence, and that entire elite mission would fall apart. The Thunderbirds taught me a very valuable lesson early on, and it's this. Nothing of significance is ever accomplished alone. Nothing of significance is ever accomplished alone. It goes without saying that finding the cause and the cure for Alzheimer's is a pretty significant thing. And the beauty of Alz PI and everybody hosting us here and this whole team up here, right, is this idea that it's gonna take this village. It's gonna take all of you together, trusting each other, pushing the envelope, putting your egos aside, having the courage to think outside the box, to try things, even though you know failure is an option. But with great risk comes great reward. And for all I know, sitting in this room is the person who discovers and the team that discovers the cause and the cure of Alzheimer's. And that's pretty damn significant. So be proud of yourselves. What you are doing is honorable, it's noble, and it's good. Don't ever forget that, especially on the hard days, all right? We've talked about courage and trust. We're going to end here on vulnerability. I know we got a panel after it. There's only me and the panel standing between you and sushi. So I know what's going on here. Let's talk a little bit about vulnerability. You know, a lot of times when you bring up that word vulnerability, people sometimes get uncomfortable, right? Their eyes roll in the back of their head and they're like, oh no, is she going to make us talk about our feelings, right? Here's what I've discovered about elite people and elite performing teams that I've been on. Like, if nothing else, it's that they have a culture of vulnerability where they're willing to put their egos aside and say, here's where something didn't go according to plan. Here's where mistakes and failures happened. Here's how we as a team can learn from that. But vulnerability is also about being vulnerable with yourself. We are human beings here together at this conference to try to learn to help other human beings. Everybody in here has a story. Everybody has cared for, loved, or taken care of a patient who has a story, right? Let me ask you, what is it in your life, I guess, or what is it that gives your life meaning? What is it that you value and why? Why is it that you do what you do? That picture right there, that's what gives my life meaning. So my awesome husband, Paul, of 22 years, retired Lieutenant Colonel, flew the F-15E with me, that's where we met. Our now 14-year-old twins, which blows my mind, Garrick and Nora, and our crazy dogs, Sailor and the Diva. Oh man, this one right here, Hoyt Vey. She's a wolfhound, she's a diva, and she's called Sprite. But that's what gives my life meaning. And I started out my conversation with you today by saying, what in the world am I doing here? Right? What in the world does an old washed up fighter pilot, right, and a hairy mother of twins have in common with all of you? You know, one of the things people ask me a lot is like, how did you end up in front of us? Like, if your career was going so well, Colonel Malachowski, right? It was Michelle Obama's military aide. My career was going really good, okay? Why aren't you still in the military? I get asked this all the time. Well, the fact of the matter is that my military career came to an end, completely unwelcome, unexpectedly, boom, overnight. Back in 2017, I was medically retired from the United States Air Force, medically retired from the career that I love. Overnight, boom, everything was gone, right? Let me take you back. 2012, I was a lieutenant colonel commander of the 333rd Fighter Squadron at Seymour Johnson Air Force Base in Goldsboro, North Carolina. I was physically fit, mentally fit, spiritually fit at the height of my career. There is no greater honor than commanding a fighter squadron. And I was hanging out doing pretty good. In the summer of 2012, I came down with what felt like the summer flu. Fever, malaise, fatigue. For 2 weeks, it didn't go away. And then at about the 2-week point, I presented with this giant, what I now know, EM rash, but a giant bullseye rash on my hip. I went to my military medical providers. I said, I'm not feeling well, haven't been feeling well for 2 weeks. Oh, by the way, look at this really weird rash. Hindsight being 2020, I wish I knew then what I know now, but I didn't. Neither did my military medical providers. They looked at me and said, quote, we don't have Lyme in North Carolina, end quote. That was the day that I became chronically ill for the rest of my life. It's a spider bite. Here's 5 days of doxycycline. Here's some steroid cream for your skin. Get on it. Y'all know that that didn't work. Within 3 months, I started having severe neurological issues, pins and needles, paresthesia. I was starting to have struggles reading and writing. I started having problems word finding. I was dropping things with my right hand, dragging my right leg, tripping and falling. They didn't know what was wrong with me. They grounded me from the jet. They said, you can no longer fly. We don't know what's wrong with you. We can medically board you now out of the military, or you can stay, but you can't fly. I said, I want to stay. It's not the flying that I'm going to miss. I'm going to miss being a part of a team. And I could still be a part of a team, and I can still lead airmen. I want to stay in. And so they let me stay in. They sent me up to Naval War College in Rhode Island. About 9 months later, I'm walking around Rhode Island feeling really bad because my symptoms have gotten really bad. The fatigue, the pain, the brain fog. I can't read, I can't write. I would get lost driving home. I would be in a grocery store and look around confused and not know what a grocery store was. Sound like something else that sounds familiar? I don't know a lot about Alzheimer's, but it sounds a lot like that. A lot of confusion. Went hiking out there in Rhode Island, came home and pulled an engorged tick off my leg. Lightning struck twice in less than 12 months. I didn't know then what I know now, but after that second tick bite, I started adding immense night sweats and 100 to 101 degree fever every day. My symptoms would continue. I would be a medical mystery. All right. They did a MRI of my brain. They said, you have non-specific white matter lesions. Maybe you're getting MS, but I didn't meet the diagnostic criteria for that. So over the next 4 years, the symptoms waxed, wanes, and my symptoms would grow until at my very worst, my symptom list was 63 long. 63 distinct symptoms. My very first symptom was dental pain. 63 symptoms long, covering every single system in my body, including the horrible interstitial cystitis and anything in between. By this time, I was back in Washington, D.C., working at the White House for Michelle Obama. I woke up one morning in July of 2016, so almost exactly 4 years to the day from my rash. I woke up and I was essentially locked in. I couldn't move and I couldn't speak. I had to wait for my husband to find me. Terrifying. I went from this totally high-performing elite fighter pilot overnight to someone who was 100% dependent on other people for all of my activities of daily living. My career was gone, boom, in the blink of a bite. And I remember the Air Force still didn't know what to do. They cut bait, thank goodness, and they sent me up to Massachusetts General Hospital, where I was finally diagnosed. They cast the net very, very wide. I was diagnosed with late-stage neurological tick-borne illness. specifically Borrelia burgdorferi, Borrelia hermsii, Babesia microti, Bartonella hensley, and Anaplasma. Yeah, how about them? And I remember saying, well, we have a diagnosis now. And actually, I couldn't talk. I was in a wheelchair. My husband talked for me. We have a diagnosis. Give her treatment. She wants to get back in that jet. And I remember the doctors looked at me and said, it's been too long. You're never going to fly again. It's going to be about 2 years of treatment to try to get you back to a quality of life worth living. And so for the next, let's see, 9 months, I laid in bed, unable to walk, talk, read, and write with a home healthcare nurse, a PICC line with IV ceftriaxone, 6 months of rifampin, 3 full treatments to get rid of that Babesia. Another 1.5 years in rehab to learn to walk, talk, read, and write again, so I can be here with all of you today, reminding you that you can break barriers, reminding you that courage, trust, and vulnerability is what it takes. So when people ask me, Nicole, how did you go from fighter pilot to motivational speaker? I like to remind people I have 9 months worth of words saved up and I have got to get them out. But the day of my retirement came and I was at home alone. There was no ceremony. Nobody from the Air Force called. They mailed me my retirement paperwork. Thank you for your service. And as I sat there on the couch feeling sorry for myself, rightfully so, who am I if I'm not wearing my nation's uniform? What's my contribution to society if I'm not a fighter pilot? How am I going to provide for my family? I just lost my job. All these things I can't do now because of my chronic illness. I stand in front of you as someone who's got so many things wrong. I look super healthy. I am not. On my best days, I'm about 60 to 70% of who I used to be. On an average day, I'm about 50%. You know, who am I? What am I going to do? And it hit me in that moment. I was asking the wrong question. You're a fighter pilot, Nicole. It isn't about what you can't do anymore. The real question is, what can you do with what you have right now to move forward? What can you do with what you have right now to make a difference in Alzheimer's? And as I sat there going through all this in my head, the words that came to my head, clear as day, were yield to overcome. Yield to overcome became my mantra during my recovery process. It wasn't about quitting, surrendering, or giving up. It was about full acceptance of where I was, what I had, and what I needed to move forward. So I'm going to leave you all with this, one of my favorite things to say as a pilot. The runway behind you is always unusable. All you have is the runway that's in front of you. I went over by like 2 minutes. You've done a great job. I'm not, the IDSA is up here keeping me straight. So there we go. That's what we talked about. I leave you with one last picture, my favorite one from my whole career. The jet on the left is my husband, and the jet on the right is me. Aw, yeah, not a lot of married people have that photo. And trust me, the 14-year-old twins are not impressed at all. But it's a reminder of this. What kind of wingman are you? What kind of wingman do you want to be? Who is your wingman? Look around this room. You came here for a reason. Your wingmen are in this room. The solution is in this room. Be a good wingman to each other, all right? I wish you all the best. Thanks for having me.